Welcome to the University of Washington School of Nursing Voices of Nursing podcast, where we dive deep into the diverse and inspiring stories from the heart of healthcare. This is Voices of Nursing. Hello and welcome. I'm here today with Dr. Vitor Oliveira, a researcher, scholar, and practitioner at University of Washington School of Nursing. Welcome, Vitor, to the podcast today.
Thank you very much. It's a pleasure to be here.
It's a pleasure to have you here. We're going to kick off just by getting to know you a little bit more as a person. Can you tell us a little bit about your journey to research at University of Washington School of Nursing? You've come quite far geographically and just in terms of your research and your career.
Yes, I'm from Brazil, so I moved to the U.S. 3 years ago. But before that, I had a quick experience at Case Western Reserve University in Cleveland in 2017, where I was there for 6 months. So I was in Brazil at that time. I was getting my PhD. So I got a scholarship from the Brazilian government to spend some time abroad, learning about research in other countries. And then I went back to Brazil, finished my PhD, and then I returned to the US, returned to Cleveland again for a short time, and then I moved to the University of Washington as an acting instructor. And since then, I have been working with people living with HIV. It's something that started in 2011, 2012. When I was starting grad school, that's when I decided that this is the population that I wanted to work on with. But, and just to go even further back, like my research involvement actually started when I started in college. So I decided to go for a kinesiology school because I was playing volleyball at that time, so I was involved in sports. So that's the desire that I had at that time when I was 17. And then I started to get involved in some research studies around that time. I think on my second year, I started as a research assistant for a study assessing injuries in volleyball players. And I never really stopped working on research. So it's something that it's nice to be exposed early in your career, I believe.
And very fun and rewarding, I would imagine, too.
Absolutely. There are a lot of challenges, I think, like in every career, but I like the rewards, like both professional rewards that we have. It's a fun and very dynamic career because you're working with different kind of people, you're working in different research studies. I love going like to conferences and networking with people. You get to know new people, new places. But also it's nice, especially when you work with a patient population and in the kind of work that I do, which is more related to intervention. So I work with exercise studies. So it's something designed to improve the health of the participants, not only like to diagnose or to collect some data on a cross-sectional time point. So we follow the participants for some time, so we see the improving, and also the feedback that they give to you, it's very rewarding, especially when you work with like marginalized communities and people who need like healthcare the most.
And are you doing that right now?
Yes, I have been doing this right now.
So what communities are you working in, and what's your current area of focus?
So all my study in the last years has been with people living with HIV. So both in the U.S. and across the country, it has been a marginalized community, a marginalized population. So usually people who lack access to high-quality healthcare and to lack access to services, and sometimes have like socio-economic challenges as well. So it's nice to see like a population that cannot afford maybe having a healthy diet or cannot afford paying a trainer or having access to the gym. And then we offer this kind of services to them and collect some data before and after to see how much they improve.
So what drew you to University of Washington School of Nursing to do this kind of work and work with this particular population? Because you could go a lot of different places. So why here?
Yeah, so all my work has been very multidisciplinary. So I am an exercise scientist, so my education was in kinesiology, exercise physiology, but I always worked with infectious disease doctors, social workers, nurses, dietitians, psychologists, or people from mental health fields. So, and when I started to get involved in nursing, especially nursing in the United States, I started to see how broad the nursing profession is here. Because like in Brazil, the view that you have from nurses are like the nurses that you find when you go to the hospital, someone that is gonna come and draw your blood and that's it. But in the US, I was impressed by how broad the nursing profession is, and sometimes they take several roles that in Brazil like wouldn't be assigned to them, would have like another professional taking that role. So I really got like very amazed by how the nursing field is in the US, and then I decided to continue work with these great professionals, and has been like enriching me myself as well, because gives me another perspective on the work that I do.
And nurses are just your favorite, right?
Yeah,
Obviously.
so far, yes. But especially by what I mentioned, like how broad their education and their experiences are, and how much they aggregate to the studies and to the research teams that I participated on.
And do you find that there's a natural opportunity for nurses to have impact with the community who has HIV because they interact with them regularly, and that they could perhaps provide more insight than physicians perhaps might be able to with their limited interactions?
Absolutely. But as I said, like it's a multidisciplinary work. So I don't think like nurses can do all the work, but they are definitely a great addition to the teams who work with this patient population. Especially by, as you mentioned, like sometimes they have the first interaction with the patients before the doctor. Sometimes they have more time with the doctors to work with the patients. Also here in the US, it's something that we don't have in Brazil. We have the nurse practitioners. So they can also like be the person leading the care of a patient. So there are many other opportunities for nurses here, I believe. And this concept of nursing practitioner was new to me as well here in the US.
Can you tell me a little bit more about your focus in exercise science and in kinesiology and working with the HIV population? Can you tell me a little bit more about what specifically are you studying? What are you finding? What are you trying to explore and discover?
Absolutely. So people living with HIV, once they started taking their medication, they have to take that medication forever. So it's not like some other chronic conditions. People should take their medication forever and every day. But some conditions, if they don't take the medication, like they may feel bad for a while because they're not taking the medication, but once they go back to their medication, usually their condition stabilizes. But for people living with HIV, it's a little different, because the idea of the medication is to control viral replication. So when people living with HIV stop their medication, HIV goes back to replicating their bodies, and there is a potential of having some mutations to the virus. And for HIV treatment, there are several types of medications that can be used for treatment. And these mutations in the HIV virus, they can be resistant to some specific medications. So sometimes people living with HIV are very stable in a specific medication, and sometimes they stop taking that medication and they have some viral replication, and they go back to the same medication that they were before, and that medication is not working anymore because the virus, like who replicated, started to have some mutation, so they have to try different medications until they find some that are going to work with people living with HIV. And I wanted to focus on that, because to say that like people have to take medicines forever and every day, and they started to have a lot of side effects from the medications. So the medication works very well to control the HIV, but also gives a lot of side effects and comorbidities that comes from these medications. And these comorbidities are like high blood pressure, high cholesterol, more risk of heart disease, loss of muscle mass, usually fat accumulation around the waist and the abdomen area. People living with HIV also have a higher likelihood of having osteoporosis, of having frailty. So all these conditions associated with aging that like everyone are gonna experience at some time in their lives, they happen early in people living with HIV because of the side effects of the medication, because of like inflammation caused by the virus. So basically exercise can help control and reverse all of those conditions. So when these conditions started to show up in people living with HIV, like osteoporosis, hypertension, high cholesterol, you have one medication for each of those conditions. But because the patient already has been taking medication for HIV, all of these medications, sometimes they can interact with each other, and the patients start to experience a condition that we call as polypharmacy, when they started to take a lot of medications for different conditions, and sometimes one medication affects other medication. So our idea with exercise and diet is to change their lifestyle, to try to control these other comorbidities in hopes that the patient doesn't need to add more medications to their treatment and can, like, maybe with a better lifestyle, control like their blood pressure or their cholesterol.
Which would then make them more likely to keep taking their medication that they need for HIV.
To keep taking their medication that they need for HIV, and has less chance of them to be needing more medications and having more side effects and having all these drug interactions.
So better quality of life across the board as well.
That's the idea. With a better lifestyle and less pills.
So what drew you, so we know that you have a kind of a love of exercise and the human body and how all these systems work together, and that you have a multidisciplinary approach. Mm-hmm. So what drew you to working with people living with HIV?
Well, that started as a personal experience. I'm also someone living with HIV, and I was diagnosed very early when I was 21. And at that time, I didn't know anything about the condition. So when I realized that was a condition that I would have to live for the rest of my life, I went back to study what that condition is. And like I went to study kind of like deeply. I went to go medical textbooks or understand like the very basics of the disease, what that could cause to my body and everything else. Mm. And I started to access public health system in Brazil to get treatment. So Brazil offers universal health care for everyone, but also we have the private health care. So usually the public health care works very well for the basic stuff, like if you need a primary doctor, works very well. But sometimes if you need some specialists, that can take a while. So, and Brazil for many years was a leading country in the world for the HIV treatment. So Brazil, if I'm not wrong, was the first country to offer universal access to medication as well for HIV. So people living with HIV in Brazil doesn't pay anything for their medication.
Wow.
That started, I think, early 2000s or late 90s.
I did not know that.
Yeah, so it's a very cool thing, right?
Mm-hmm. Yeah.
Also at that time, because like HIV was spreading out across the country, Brazil started some specialized clinics for HIV treatment across the country. So in all of the major cities, you have a clinic specific for HIV and infectious disease. So even though there is a specialist who works there, an infectious disease specialist, but because Brazil put a lot of like funds in these clinics, so the access of care for people living with HIV works very well, even though they need a specialist for their treatment. Mm. So I started to access these clinics, I started to access care for that, and I used to see the other patients that were there, which were people like very debilitated and people with a very low socioeconomic condition, with no access to information. and no access like to other healthcare outside of those clinics. And that's when I decided to start like focus my attention on maybe, that's when I decided also to go back to grad school. And then I also decided that I wanted to focus on research because it's something that, like here in the US, if you want to work in academia, usually research is a very big component of your career and your job application. So when I decided to do grad school, I decided that I want to focus on research since early on in my career to like aspiring for a job position in a university. And I decided just to put everything together, like my personal experiences, everything that I was learning about HIV, the desire and the need to make some research for grad school, and the experiences that I was having with these patients. I decided to help them and bring to them the knowledge that I had regarding lifestyle and everything that I was learning about HIV.
I love how you describe it as bringing it all together. So areas where you personally were invested and then you leaned into that, and then also areas of interest in how you could help others, and then also adding to your knowledge and growth in the research area. So at the time, was this at the time where you were doing kinesiology and working with like volleyball players and things like that? When you first decided you were going back to grad school, what kind of work were you doing at the time? Just curious.
Yeah, actually, I started college very early. So I finished high school and I started college when I was 17. So when I was 21, I got my degree. So I didn't know very much what I wanted to do with my life, as you can imagine, at 21.
I can imagine. I was also a young graduate, so I totally, when you said that, I was like, I get it.
So my family never like influenced my career decisions. They left me very open to make my own choices.
Well, that was nice of them.
Yes, has some pros and cons, but we can go back to that later.
Of course.
Because I was playing volleyball, I was like crazy about volleyball at that time. I still am, and I still was throughout my life. And my only desire, like when I was 16, 17, was like to be a professional player or to be a coach. And then the way to go in Brazil was to go to kinesiology school. Actually, in Brazil, the degree is called physical education, which is similar as kinesiology here in the US. But that's the route you go if you want to be like a personal trainer, or if you want to be a sports coach, or if you want to work anything related to movement. So that's what I decided to do. And then when I finished college, 21, I got diagnosed with HIV. In the following year, I was 21, 22. And I started work in the kinesiology field. So I started to work as a personal trainer. I was also coordinating some social projects offering sports activities to low socioeconomic communities. And then that was hard to make a living off that, out of that.
It unfortunately can be.
Yeah, so I think when you are an early professional, it's very difficult to make money, and especially in that field in Brazil was even harder. And then usually in Brazil, position in academia is something very stable. And the way to get this position is to have a PhD. So I took a gap of like maybe 5 years between finishing college and coming back for a master's. And then during these 5 years, I was working as a personal trainer. I was working as a volleyball coach. I also decided to live abroad. So I lived in New Zealand for 1 year.
You lived in New Zealand?
Yeah,
how was it?
which was an amazing experience.
Good.
So I was there for 1 year as well. And then after returning to Brazil and working maybe 2 or 3 more years, that's when I decided to go through grad school. And then at that time, I also got a position as a physical education teacher. So I was working part-time with that. And then I had my grad school together with this position as well. So I was very busy during that time.
You're incredibly busy. Oh my gosh. I think a lot of our listeners will relate to the journey that you've described. You know, we have listeners who are probably at some point of the journey that you've been on and wondering, oh, well, could I do something like that? Could I have that kind of impact? Or, should I consider going into academia? And I wonder what you might say to those folks who are considering that, or maybe thinking it's just too big or too hard, or is it even possible?
Yeah, it's even possible. Like, we are here, so we can show that this is possible.
True, that's fair.
But I think, like, I have a lot of friends who did the same kind of, like, degree with me in college, and now they are in other fields. So usually life is not, like, something stable. It's never stable, actually. And I think, like, to me, I'm an example of someone who decided to take a specific, like, position, a specific field of the knowledge when I was 17, and I have been following that. But before, like, I started grad school, I had a lot of thinking as well regarding maybe switching to another position, switching to another profession. I have a lot of interest sometimes, like, because I focus on exercise and kinesiology, usually in Brazil, that's known to be something for, like, lazy people. Because it's very easy to get in college for physical education and kinesiology in Brazil, because the stakes are very low.
Okay.
So usually people who don't want to study much, they go to this route.
You're telling on yourself over here.
But it's not my situation. That's what I want to go back. So it's not my situation. I was always, like, hard working at school. With the grading that I got in my university, I could even get, like, to med school or any other schools there.
Yeah.
So that's why sometimes I said that I have, like, a mixed feeling about my family not, like, trying to help me in making my choices. Maybe I would have made a different choice at that time. But I also had a nice an interest, like, in architecture or engineering. So when I decided to go through grad school, I was between changing my career to something related to, like, civil engineering or architecture, or going to grad school.
So you were thinking about it. You were kind of at the decision point.
Yes, about switching to a different profession. And when I started to analyze the pros and cons of both of them, basically both would take the same time to complete. But if I had done grad school, which I did, after I finished grad school, I would be, like, in a whole another level in my field, because I'd have a PhD and I'd have, like, more than 10 years of experience in kinesiology. Yeah. While if I had switched my career, I would take the same time to complete, about 5 to 6 years. And then I would be, like, a freshly graduate in that field as well, and would have to start over in a new field. So when I started to think about that, I decided for grad school. But I have had friends who made the opposite. So I had a friend who just graduated in med school January of this year, and she is 38. So she was a veterinarian.
Oh, veterinarian.
And then she decided to go for grad school to work with humans instead of pets. And she graduated. Yeah. So I have a lot of people making big changes in their lives and graduating when they are, like, between 35 and 40 and starting all over.
Yeah.
So, so going back to your questions, if I have any advice, is that just go, like, follow your passion, try to have experiences in things that you love and things that you believe, and see if that's a good fit for you. And don't be ashamed if you get at any point in your career that if you feel like that was not the correct choice, or if you want to switch to something different. Here in the US as well, I have many friends, especially working in different careers and coming back for nursing. So I have a lot of friends who work in tech jobs. So they say they went for the tech industry to try to make more money, and then they start to see how the quality of life is very low, and they wanted to work more with people. They wanted to help more people in a different kind of way, and they're coming back to nursing professions, to nursing school, and trying to get in this new field. So life is very dynamic. Just don't go afraid to follow our passion and go for it.
It's zigzaggy. It doesn't go in a straight line, and
that can go.
It can for some folks, but everybody's journey looks different, I think, is what you're saying.
Yes.
So a little bit of a pivot, actually, kind of, we went from the past and now we're looking towards the future. So my next question is, where do you see your field headed? I know it's a really broad question, so feel free to go whatever direction with it you'd like. But what do you think the future looks like for, your discipline and the community that you're trying to help?
So for people living with HIV, regarding like the people living with HIV overall. So in the beginning, in the late 80s, early 90s, these patients were having a very low life expectancy with the new disease. No one knew what was going on. We didn't have medications to treat that. So the life expectancy was very low, and people couldn't even make plans for themselves. For example, in my situation, that's why I went to New Zealand, for example, because I had this desire to live abroad. And when I was diagnosed with HIV, like basically you think, I don't know how long I'm going to live. I don't know if I'm going to be able to travel abroad. That's something I want to do in the future, so let me do this right now. Actually, there was a decision that I made like maybe in 1 or 2 months. One day I decided to go, and like in 2 months I was there. I basically quit all my jobs, sold my furniture, sold my stuff, and went with like nothing planned.
You're such a go-getter, Vitor. Once you set your mind to doing something, you're like, we're doing it.
So it's a very, so the sentiment right now, it's very different because these patients are living longer. A lot of people say that if you take the HIV medication, you have a normal life. I wouldn't say it's a normal life, but it's a life with like the similar life expectancy of people living without HIV. But that comes with challenges, as I said. There are comorbidities, there are challenges that come with taking the medication. You have to go to frequent like doctor's visits and getting lab work. So add some burden to your life. So as this population is living longer, they started to face all of the challenges that people without HIV are facing. And as I mentioned, in an earlier age, so people started to experience like frailty before than expected, started to experience osteoporosis before expected. So that's the way the field is moving also. Like in the United States right now, more than half of the population living with HIV are 50 years and older. So this population like is aging and is becoming like a geriatric population as well, with all the challenges that come with that. So there are a lot of research funding, a lot of research interest in older people living with HIV. That's the focus of our studies as well. We have been only working with people who are over 50. And the idea is to change their lifestyle, try to avoid like increasing medications to them, because all of these other comorbidities as well, sometimes they require like a new medication, sometimes they require a new specialist to be involved in the care. So if we can avoid the development of these conditions throughout a better quality of life and throughout a better lifestyle, that can improve the quality, the life and of these patients as well that are aging with HIV. So that's the route I think the field is going. So outside of my research, I see a lot of research still like research on the cure for HIV. I think that's the main goal. But also, while we do not find a cure, the idea is to improve the quality of life of people living with HIV. So there are a lot of research as well on new medications and new modes of administering the medication. So for example, we just had one new medication approved earlier this year that is an injection that people get every 2 months instead of taking like a daily pill. So basically that only requires six doctor's visits throughout the year to take those shots every 2 months.
More like someone dealing with a treatment for arthritis or multiple sclerosis, where they can have these sort of spread out and have some respite or reprieve between.
I'm not aware of how the treatment for these other conditions work, but I believe that's something like that.
Some of those can be that way,
Okay, that can be like an injection as well?
Mm-hmm.
Okay,
yes.
So I think the newest medication is called carbotegravir, and it's basically one injection every 2 months without the burden of the daily pill.
It is burdensome. It is. And as you're saying, as they age, I think of my grandparents and their shelf of just so many medications. Mm-hmm. And so as they're getting older, some of these things can't be helped. You're just going to add more and more medication to your daily regimen. So describing that as alleviating a burden, I think is really powerful.
Yeah, so that's where the research is going. Like, there are a lot of research on new medications. The focus that my group and I have been taking on improving lifestyle, especially through exercise and diet and mental health services. One thing that I don't really focus my research on yet, but there is a lot of studies on the intersection between HIV and substance abuse, because injectable drugs are one of the routes for HIV transmission, and it's becoming a big problem. This intersection is becoming a big problem in the US as well. Like, we all know how substance abuse is spreading across the country, but also the intersection of HIV with that has been very challenging, because the way the route that health agencies are working on nowadays is, while we don't find the cure, let's treat the people living with HIV in the best way possible, and possibly this way they're going to take their medications daily, and then they can stop preventing the virus, spreading the virus. Because there are a lot of research as well showing that if you take the HIV medication, you become undetectable for HIV on your bloodstream. And people who are undetectable for HIV cannot transmit HIV to other people, even when performing like condomless sex. Research has been shown that there is a message that has been circulating among HIV, and the message that is trying to be transmitted is that undetectable equals to untransmittable. So if you work in this field, or if you read anything about HIV, you're going to see sometimes like a logo showing U equals U, which means undetectable equals untransmittable. So the focus of the health agencies, World Health Organization, is to treat as many people with HIV as possible. This way they become undetectable and they cannot transmit the HIV to other people. And it's something that in the context of HIV and substance abuse doesn't really work very well, because these patients are not taking their medication, so they have a high viral load, so the transmission of HIV among this population has been very high.
So we see that borne out in the data, that as usage continues, that also we're seeing more increased transmission rates amongst that population.
Yes.
Okay. So as you've shared about your research with kinesiology and the impact that healthy living and just changing lifestyles can have on populations living with HIV, there's a lot of hope. I'm hearing a lot of hope about the future, and even as we're seeing the shift in the population to more folks living longer, right? These are all really positive things. And I think that our country has come a long way, our society has come a long way in having these conversations. And I wonder what your thoughts are around maybe the shifting attitudes, where previously there's only been stigma around people living with HIV. What are your thoughts on that?
Yeah, so stigma is still very present among people with around and among people with HIV. So, for example, I'm from Brazil. So Brazil, it's still more like a Catholic country. So we still have a lot of stigma as well around a lot of questions that are discussed here in the US, including HIV, people living with HIV transmission. So usually people keep their diagnosis to themselves. So, for example, when I was working in Brazil, my first study was an exercise study as well. So we were following the participants for a while so they get more comfortable in sharing their experiences with us. So I had heard many sad stories from these participants. That happened like before in the beginning of the pandemic, but we had participants, for example, mention to me that one participant in specific that I remember and got very on me her story, even though it has been so many years. But she mentioned to me that when she found out that she had HIV, her family basically built a bedroom outside of the house on the same land, and she had to be restricted to that area and could not access like the main house. And they would take food for her in that bedroom. And she had a lot of struggle, like taking the medication and accepting her condition as well. And you can imagine how hard it is for someone like to not have any support like among their peers.
To be isolated like that.
Just to be isolated.
Very physically and mentally isolated.
Yeah, even physically and building another place for her. I remember another participant as well. Some of the medications for HIV, especially like the strongest medications and medications that were developed early, some of them had to be kept inside a fridge to keep like their life. Let's say this way, to keep working. So I remember another participant where no one knew about his condition. And he could not keep the medication inside a fridge in his home. There was a man. So he used to live like in a very neighborhood in the outskirts of the city. And there was like a small river close to his place. So he mentioned to me that he used to keep the medication inside this river, like tied in a bag or something, and every day he used to go there to get his medication in an attempt to keep like the medication a little cooler than the environment, because he didn't even have access to a fridge for that. So there are many sad stories that I heard, and also we see that these things still keep going on. So we see all of these discussions regarding sexual health education, and all of this like goes into like HIV stigma as well. We also always see like people making jokes about living with HIV, sometimes regarding your sex life. If you have more sexual partners, people start to make jokes about infectious disease and HIV. Even among like gay people, we hear that. Other things that I can mention, for example, in Africa, there are a lot of countries criminalizing having HIV. So only the fact of you having HIV that can be considered a crime. Here in the U.S., there are some states. I cannot name any of them, but I know there are some states, for example, where having HIV and not telling your partner that you have HIV, that can be considered a crime as well. So still there are many initiatives around the world to criminalize being gay or criminalize having HIV, which puts this population much more like at risk for stigma, and by not like trying to access the services offered to them regarding sexual health or regarding HIV treatment. What I can add on this matter as well, I have been talking about like HIV and substance abuse, about being gay and the gay population, but also HIV affects everyone. We nowadays know that, but still there are some denial of that. I was hearing a podcast 2 days ago about one guy in UK. So he has a podcast only to go over like news regarding HIV. And he was talking about a research that was done in the UK where a lot of straight people, they feel that, they say that they are not at risk for HIV because HIV is a disease of gay people. So still there are a lot of people who thinks that they cannot contract HIV or be infected by HIV just because of their sexual orientation.
Such a misconception.
Such a misconception, yeah. And all of this, especially like when you think about people living with HIV, all of this has strong effects on their mental health. So all of this stigma, all this discrimination that can relate it like to anxiety and depression and a lower quality of life. So there are a lot of efforts as well from the health agencies and research funding agencies in fund research on HIV and mental health as well, because that affects a lot our population. So for example, we have the health study, which is an exercise study for people over 50 and who are living with HIV. So the pandemic also had great effects on our population, but I remember a specific case of people coming with for the study where the pandemic came and these people were like already like more isolated with no social connections, but people coming to the study and reporting that like during the COVID pandemic, they basically didn't do anything for like 2 or 3 years and didn't even leave the house because they were like living on disability, they were having their doctor's appointment virtually, they were receiving the medication through the mail, they were ordering food from some grocery shopping service that delivered to them as well. So they were like completely isolated, and it's interesting how once they started the study, they started to have more contact with people, they started to exercise, how their anxiety levels and depression levels have like improved throughout the exercise.
It's so interconnected.
Right? Yes, interconnected. And as I said, sometimes like this stigma and discrimination like makes people even more like to live for themselves because they don't want to be dealing with these experiences. Sometimes they have so many bad experiences that they don't want to like expose themselves and maybe have been facing these issues again. So people kind of like start to keep to themselves and be more isolated, and then all of these mental health issues just come through.
And elders are more prone to isolation too, and isolation-based anxiety, and like you were saying, the comorbidities that come with that. I can't imagine, an elder who is also facing that potential stigma and the health impact that can have. And then also, I wonder what the education is like for folks of that age. You said that it was difficult to get information. I wonder, if you're aging, 50 isn't that old, right? Mm-hmm. Most 50-year-olds know how to use the internet nowadays, but, I wonder if the population who is older than that may have some difficulty getting more accurate information about their conditions.
Yeah, absolutely. That's a difficult, especially if they are not like out and about and meeting people and accessing services, and if they not have like a good understanding on how to use internet or social media, they basically have no way to get information and have to rely on these technological resources and social media for that. One interesting thing that we have been seeing some research on as well, like a lot of my research is dedicated to sarcopenia and frailty, which is related to loss of muscle mass, loss of muscle strength, and that leads like to disability. So people get more less movement, doesn't have the opportunity or the ability to get out and do stuff around the city, or to do the daily activities by themselves. And one thing that I haven't heard before, but I was reading a paper a while ago, is regarding social frailty. And I was interested about the concept, and I went to give some look at what that was. But basically, social frailty are related to the loss of independence on your muscle strength and muscle mass, that prevents you from being social and from preventing social services and activities as well. So also this disability and frailty, also people start to lose their ability to conduct the activities in their daily lives, basically just stay inside and stop accessing these services.
And so if you don't use it, then you start to lose the ability to do it, yeah.
Absolutely. And that's the idea of getting people moving and exercising. And it's I say that exercise, it's a very powerful tool, but also has one drawback, which is very bad, which is when you stop doing exercise, basically everything that you built goes away. We all
You just
know
put the finger on it.
Yeah, so it's not something that you do and then you achieve like a specific point and you're going to keep that for the rest of your life if you stop. So you need to keep doing after that. It is also a challenge with this patient population because like we see in many studies with people with HIV and other populations as well, people go to the study, they do very well during the study, the exercise study, they improve a lot during the study, and then they finish the study, we collect the data, they had a lot of improvement, and then we talk to the participants 3 months later, 6 months later, and they say that they didn't do anything else after the study. So it's very hard for them to keep doing by themselves, and it's something that we are trying to achieve on the health study. So health study, basically, we have 2 interventions. So first is an exercise intervention for 4 months. And after the exercise intervention, we have like a follow-up where we follow them for 3 additional months to try to help them to exercise by themselves. So we offer some education, we offer some motivation, and we see the participants once a month just to check on them and see how they are doing in keeping their exercise habits, which is more important than doing this for a short term and stopping.
So the sustainment activity is kind of where you're starting to see some of that longer term habit changing.
Yeah, this is the key for habit changing, and we still have a lot to move on that area, and it's something that our group has been taking on this role in this new study.
It changes how you think about it if you know you're going to have to talk to somebody again in a few months, right?
Yeah, you need to report something positive. So.
Yes, exactly. Yes, dentist, I've been flossing this whole time, right? So giving some kind of connection point, though, and I'm sure that means a lot as folks are experiencing isolation, having more sustained relationships with their providers, or in this case, with the researchers.
Yeah, absolutely. I think the social aspect is something very, very powerful because both from our participants in the health study and something that I used to hear from my career as well, and when I worked as a personal trainer, I used to work with clients that were like exercising for many, many years. They knew exactly what they should do, but they were paying me because they wanna accountability. They wanted someone waiting for them at the gym, so they would show up on time and having that appointment to go. And we hear this from our participants in the health study as well. So there are some participants as well that are still functioning and working and have very high-paying jobs and have access to gym and trainers and everything else. So their desire to come to the study is to have some trainers with them, to learn how to do that properly. A lot of our participants like the approach of this sustained exercise, of this follow-up phase. So this is what brings a lot of them to the study, because a lot of them report that they have exercised before and then they lose the interest. But we also have some other participants that they don't have this social connection outside of the study, and the study has been the only opportunity for them to go somewhere, meet people, and talk to some. We have amazing exercise trainers here in Seattle that are doing a great job in teaching the participants not what to do, but how to do and why to do that. And that has been very helpful for them to keep their exercise habits.
That's powerful stuff, Vitor. Thank you so much for coming on this podcast today and for just bestowing all of this fantastic knowledge and for sharing your experiences and your expertise with our audience and with me. I've really loved talking to you today. Thank you so much.
Okay, thank you as well. We love being here and sharing these experiences.
Yeah.
And if any of the listeners want to hear more, feel free to reach out.
Where can they learn more about the study that's going on?
We have a web page here at the University of Washington. So I have been working with Dr. Alison Webel. So the lab page is called the Webel Lab. It's where we present all of our research that we are doing now and research that were done before regarding exercise for people with HIV. So we have been doing some very nice studies on that field. Also, we published some papers regarding our research findings. So if you are interested in research for young graduates that are starting this field, there is a website from the National Institutes of Health. It's where everyone goes to find papers. It's called the PubMed. Basically, everything that is published in research is displayed in this website. So that's where you can find our research as well.
Thank you so much. So Dr. Vitor Oliveira at the Webel Lab, and that's WEBEL-LAB at University of Washington School of Nursing. So please look up Dr. Vitor Oliveira or Dr. Alison Webel and the fantastic work being done and expand your mind as my mind was expanded today. Thank you so much.
Thank you as well.
Thank you for tuning in to University of Washington School of Nursing's Voices of Nursing podcast. Join us next time as we continue to explore topics vital to nursing, health, and well-being. Until then, stay informed, stay inspired, and stay engaged. And don't forget, follow Voices of Nursing wherever you listen to your favorite podcasts so you'll get every show as soon as it's released.